Excuse me, ma'am. What are you doing here?
I'm the ICU nurse. See my badge.
We still need to check.
I've been assigned to this patient. My shift just started.
You need to step aside for verification.
I'm staying with him, monitoring his levels.
You're not on the visitor list, right?
I'm not a visitor.
Verification's coming down. 7.
The scene unfolds in a mid-sized urban hospital inside the intensive care unit. Monitors beep intermittently, ventilators hiss, and nurses move steadily between patients, checking vitals, adjusting equipment, and logging updates into digital charts. Visitors pass quietly along the hallways, some speaking softly in languages not immediately recognized by staff. The ICU operates on strict schedules, with each nurse assigned to specific patients and responsibilities. Staff members are accustomed to high pressure, rapid decision-making, and continuous observation of patients' conditions. On this particular morning, 2 ICE agents are performing routine checks near patient rooms. Their presence is authorized under federal protocol, requiring coordination with hospital administration. Agents are instructed to verify identities and ensure that only authorized individuals interact with certain patients, particularly in cases involving immigration-sensitive circumstances. Their procedure typically involves asking direct questions, requesting identification, and observing for any irregularities or unauthorized access. The nurse approached by the agents is fully engaged in her duties. She has a clearly displayed hospital ID and is performing routine checks on a patient recovering from surgery. Her movements are professional, precise, and consistent with standard ICU practice. The agents, observing her from a distance, misinterpret her proximity to a visitor speaking limited English as potentially irregular. This misreading occurs not from malice, but from a procedural reliance on visual cues and timing, compounded by an assumption about who should be present near the patient. The misinterpretation highlights subtle patterns often seen in institutional interactions. Hospital staff are regularly subject to quick assessments based on appearance or timing rather than thorough verification. In this case, the nurse's professional credentials and clear identification are initially overlooked. Agents follow protocol by questioning her, yet the system does not immediately flag her as authorized. The procedural lapse is small, an ID not scanned at the precise moment, but it creates a window where misunderstanding can escalate. No one raises voices, no physical confrontation occurs, yet the situation quietly demonstrates how assumptions and procedural shortcuts can converge. The ICU environment, normally focused on patient care, becomes a space of scrutiny and hesitation. A single unverified assumption is enough to create tension, illustrating the potential for escalation even when all parties are acting within their formal duties. This factual context sets the stage for the incident. A trained professional, performing standard hospital duties, is questioned not because of behavior or actions, but due to a misread situation and reliance on incomplete verification. The groundwork is laid for the subsequent escalation, emphasizing the stepwise, procedural nature of what unfolds next. The nurse at the center of the incident has worked in the ICU for over 8 years. Her career began shortly after graduating from a respected nursing program, where she completed additional certifications in critical care and patient safety. She is known among colleagues for meticulous attention to detail, a calm approach under pressure, and an ability to quickly interpret vital signs and respond to patient needs. Her daily routine includes rounding on assigned patients, updating charts, coordinating with physicians, and mentoring newer staff members during complex procedures. She typically starts her shift by reviewing patient notes, confirming medication schedules, and checking that equipment is functioning correctly. Her work is methodical. She follows protocols rigorously, yet remains flexible when emergencies arise. Her reputation within the hospital is strong. She has been acknowledged in internal reports for reliability and efficiency. Colleagues often describe her as a steady presence in the ICU, someone who notices subtle changes in a patient's condition before they become critical. Despite her experience, she has encountered minor instances of misjudgment in the past. On one occasion, hospital security briefly questioned her presence in a restricted area while she was assisting with patient transport. The situation was quickly resolved when her credentials were verified, but it left a subtle mark, a reminder that even experienced staff can be misidentified or doubted based on circumstance, timing, or simple oversight. This prior episode was procedural in nature, with no emotional fallout, but it provides context for understanding how the current incident unfolded. Outside the ICU, her life is structured around careful planning, reflecting the precision she brings to her work. She maintains continuing education in critical care, participates in hospital safety committees, and engages in small community outreach programs related to health education. Her professional identity is closely linked to competence, preparation, and reliability rather than public recognition or attention. Her interactions with patients and visitors are calm and informative. She has experience working with individuals who speak limited English or who are unfamiliar with hospital routines, adapting her communication style to ensure clarity. These skills, however, were not immediately recognized by the ICE agents, who relied on surface-level observation rather than verification of credentials or context. This section of the narrative establishes her professional credibility and normal routine, demonstrating that the unfolding incident is not caused by any unusual behavior or deviation from protocol. The nurse's prior misjudgment, brief, minor, and procedural, serves only to illustrate that even seasoned staff may be momentarily questioned or misidentified in high-security environments. It highlights that the current misunderstanding is procedural rather than personal, rooted in assumptions and protocol gaps rather than error or misconduct on her part. By grounding her backstory in daily routine, professional competence, and minor historical context, the narrative frames the incident as a realistic scenario. A qualified professional's presence questioned due to timing, circumstance, and procedural oversight, rather than conflict or negligence. The nurse enters the patient's room, checking the electronic monitor for updates on vital signs. She adjusts an IV drip and makes a note on the digital chart, scanning each reading carefully. The patient is stable but recovering from a recent procedure, and the nurse follows her usual protocol, checking medication schedules, ensuring alarms are set correctly, and preparing the room for any required tests. Outside the room, one of the ICE agents walks down the hallway, observing activity near patient beds. His attention is drawn to the nurse's movements and her proximity to a visitor speaking quietly in the corner. From a distance, the situation appears unusual. A person not immediately recognized as staff is interacting with the patient's environment. The agent approaches slowly, maintaining procedural caution, and calls out politely. "Excuse me, can you step outside for a moment?" The nurse turns, keeping her posture professional. "I'm the assigned ICU nurse. My shift just started." She gestures toward her clearly displayed hospital ID badge. The agent nods slightly but does not take the ID. "We just need to verify who is in the room." The nurse glances back at the patient who is quietly resting, then toward the visitor who has been waiting politely. She speaks calmly. "I'm performing standard checks. I've confirmed medications and vitals. You can see my credentials here." She taps the ID again. The agent steps closer, scanning the badge quickly. The information is clear, yet he hesitates, noting the visitor nearby. Procedurally, he cannot dismiss the possibility of unauthorized presence. He repeats, "We need to make sure only authorized personnel are here." A colleague of the nurse passes the doorway, glancing at the interaction. She gives a subtle nod but does not intervene, following standard protocol, letting the assigned staff handle verification unless escalation is requested. The nurse maintains composure, continuing to monitor the patient's vital signs while keeping her focus on her professional tasks. During the verification process, a small procedural misread occurs. The nurse reaches for a piece of medical equipment to adjust an alarm, a routine motion for patient care. The agent interprets it as unusual movement, another point to reinforce his caution. The visitor shifts slightly, drawing the agent's attention and adding context to his uncertainty. No voices are raised. The tone remains calm. Each exchange is short and clipped, focusing on facts rather than argument. Nurse answers questions, repeats credentials, and demonstrates her role through actions, checking vitals, confirming equipment settings, and recording information digitally. Each step is standard ICU procedure, yet it contributes to a cumulative impression of uncertainty from the agent's perspective. The hallway remains quiet, punctuated only by monitor alarms, soft footsteps, and distant conversation. The nurse's routine, methodical movements contrast with the agent's procedural caution. The situation escalates slowly, not through conflict, but through the intersection of timing, observation, and assumption. The scene illustrates how ordinary professional actions can be misread when verification is delayed or overlooked. By the end of this phase, the potential for misidentification is fully apparent. The nurse has performed every step according to protocol, her badge visible, credentials clear, and patient care uninterrupted. Yet the situation teeters on escalation, highlighting how procedural reliance and misinterpretation of routine actions can create tension in high-security, high-stakes environments like the ICU. The ICE agent steps closer, maintaining a polite tone but repeating his concerns. Ma'am, we still need to verify your authorization. Protocol requires confirmation for anyone in patient areas. The nurse remains calm, holding her ID badge in plain view. This is my patient. I'm the assigned ICU nurse. You can verify my credentials with the hospital system right now. She gestures toward the digital chart showing her name and shift assignment. The agent glances briefly at the visitor in the room who says nothing, standing slightly to the side. We just want to make sure everything is in order. Can you step aside while we check? I cannot leave the patient unattended, the nurse replies, her voice steady. You can verify my ID through the system while I perform my duties. I'm following proper procedure. A colleague, another nurse, approaches the doorway. She watches silently, ready to assist if necessary, but does not intervene. Her presence is quiet, observational, an acknowledgement of the situation without escalation. The agent notes her, but the focus remains on the nurse's credentials and proximity to the visitor. The agent repeats the verification request, citing policy. We have to follow protocol. It looks like there's an unauthorized person here. The nurse points calmly to the ID and to her access on the hospital system. You can see all information confirms my role. There is no unauthorized presence. I'm responsible for this patient. The agent hesitates, taking a few steps back, reviewing the ID once more. His expression is procedural, not aggressive, but there is a faint tension, a brief moment where the exchange could escalate further. The possibility of detaining or questioning her formally is implied, not acted upon. For a few seconds, the hallway is quiet except for the hum of monitors and distant footsteps. The nurse adjusts an IV line and checks the patient's vitals, signaling that her attention remains on professional duties. Her calm persistence contrasts with the agent's cautious insistence, highlighting the friction between protocol and on-the-ground verification. A small, subtle humiliation occurs when the agent suggests she might not belong in the room. No one says it outright, but the implication lingers. Her professional authority is questioned, despite credentials, years of experience, and standard procedure. The visitor shifts uncomfortably, aware that the interaction is drawing attention. The agent reviews the badge again, confirming the name, title, and department. He hesitates, briefly consulting with a second agent via radio. They exchange quiet words, procedural, factual, without drama. For a fleeting moment, it feels as though an arrest or formal detainment could occur. Nurse remains composed, providing clear, repeatable answers, allowing her actions to demonstrate authenticity. The scene maintains a quiet tension. It is procedural, realistic, and grounded. Nothing is chaotic, nothing exaggerated, but the reader senses the potential for escalation is at its peak. Finally, the agent makes a note in his system and glances at the approaching supervisor's shadow in the hallway. The quiet escalation reaches a pause. Verification is still pending, but the intensity softens. The nurse continues her duties, maintaining professionalism, demonstrating the ordinary work of ICU staff under extraordinary scrutiny. By the end of this phase, the tension is clear. Misinterpretation and procedural assumptions have created a delicate standoff. The nurse has not erred. The agents are following policy, but subtle dismissal and repeated questioning show how protocol can produce near escalation without overt confrontation. The situation is poised for the next shift, the intervention of authority that will resolve the misunderstanding. A hospital supervisor arrives quietly, walking down the ICU hallway. She observes the interaction from a few steps away, noting both the nurse's calm composure and the agent's procedural focus. She carries a tablet used for staff verification and has immediate access to the hospital's digital records. "Good morning," she says softly. "Can I assist with verification?" The nurse gestures toward her badge and the chart. "Yes, please, my credentials are on the system. This patient is under my care." The agent nods but continues to maintain protocol. "We just need to confirm authorization," he replies, tone steady but firm. The supervisor taps on the tablet, entering the nurse's ID number. Within seconds, the system displays her credentials, role, shift assignment, and department. It confirms she is the assigned ICU nurse for this patient. She is also flagged as in good standing with all required certifications current. The agent reviews the information, his posture shifting subtly. His voice lowers slightly, professional yet hesitant. "Thank you. It appears your access is verified." The supervisor gestures toward the visitor, confirming that their presence is consistent with patient policy. The agent nods again, making a quick note in his system. Procedural caution remains, but the potential for misidentification has been resolved. The nurse returns her focus to patient care, adjusting the monitor and checking vitals. No action beyond verification is necessary. The situation transitions from tension to routine, but the sequence of events highlights the procedural reliance on immediate verification and the risk of misinterpretation when such systems are momentarily delayed. The agent exchanges quiet words with his partner. They review the verification protocol, acknowledging that the nurse's credentials should have been confirmed more promptly. Their discussion is factual, with no display of judgment or personal criticism. It is an example of procedural correction in real time. The supervisor remains with the nurse for a few moments, ensuring patient care continues uninterrupted and that the agents have the proper documentation for their records. She instructs that any future interactions follow a standardized verification process to minimize assumptions or unnecessary questioning of staff. The recommendation is procedural. Confirm ID immediately, cross-check assignment, and limit subjective assessment based on appearance or timing. The nurse resumes normal duties. Her actions, monitoring vitals, adjusting equipment, and documenting care, signal the return to routine. There is no dramatization, no reflection on personal feelings. The work continues as standard ICU procedure dictates. This moment underscores how structured verification resolves potential escalation quickly and effectively. The agents acted within policy, but the delay in checking credentials created an unnecessary standoff. The supervisor's intervention corrects the procedural gap, ensuring that the nurse's authority is recognized and that the patient's care is uninterrupted. By the end of the interaction, the quiet resolution is clear. Misidentification was procedural, not intentional, and verification confirms factual authority. The agents retreat, the nurse maintains professional focus, and the hospital protocol adjusts slightly to reduce the risk of similar incidents. The truth emerges methodically, with no dramatics, only a clear shift in operational procedure, restoring order to the ICU. After the incident, the hospital initiates an internal review. Administrative staff examine the sequence of events, including the timing of credential verification, the interaction with ICE agents, and the documentation of patient care during the exchange. Records are collected from the digital hospital system, including the nurse's shift log, badge scans, and the patient's chart updates. The goal is to identify procedural gaps and ensure compliance with both hospital policy and federal protocols. The ICE agents submit a report describing their observations, actions, and the resolution after the supervisor's verification. Their account is factual, noting the steps taken to ensure security and the eventual confirmation of the nurse's credentials. The report emphasizes that protocol was followed, but highlights the potential for procedural improvement, specifically the need for immediate access to staff verification systems to prevent similar incidents. Legal review is also conducted, though the nurse was never detained or formally questioned beyond the initial verification. The investigation considers potential civil liability, regulatory compliance, and adherence to hospital security protocols. Findings indicate that the incident arose from procedural assumptions and minor verification delays rather than misconduct on the part of any party. Recommendations are focused on refining communication channels between hospital staff and external enforcement agents. Policy discussions take place in administrative meetings. Hospital leadership considers adjustments, including ensuring badge scanning occurs before approaching staff, providing agents with direct access to on-site verification systems, and clarifying guidelines for interactions in patient areas. The adjustments are procedural and designed to prevent future misunderstandings, emphasizing factual verification over assumption-based judgment. The nurse returns to her regular duties with minimal disruption. Patient care resumes as usual, and colleagues continue their shifts without interruption. The review notes her professionalism and adherence to protocol throughout the incident. The administrative record highlights her calm compliance and accurate documentation, reinforcing her credibility as a trusted ICU professional. Media coverage, where present, reports the incident in factual terms. Articles reference a routine verification check, the nurse's professional credentials, and the procedural nature of the misunderstanding. Headlines avoid sensationalism. The focus is on institutional processes and minor procedural gaps rather than personal conflict or dramatic confrontation. Training sessions are scheduled to address lessons learned. ICE personnel review verification procedures, hospital staff refresh protocols for interacting with enforcement agents, and communication channels between agencies are clarified. All changes are operational and procedural, emphasizing efficiency, verification, and clear documentation rather than personal accountability or blame. The aftermath demonstrates that even minor procedural oversights can create tension in high-security environments like an ICU. By systematically reviewing actions, refining verification processes, and maintaining factual records, the hospital and agents ensure that professional duties continue without compromising patient care or staff authority. The incident is logged as a case study in protocol adherence, procedural correction, and operational communication, with real-world applicability for future interactions. The incident illustrates how assumptions, even when subtle and procedural, can affect professional interactions. In high-security environments like an ICU, small misreadings of routine behavior can create unnecessary tension. The nurse followed every protocol and maintained clear identification, yet the combination of appearance, timing, and procedural gaps led to questioning her authority. Studies on institutional bias show that personnel often rely on surface-level cues, such as race, appearance, or timing, when verifying identities in fast-moving situations. These assumptions are rarely malicious. They emerge from training, procedural habits, and the need to act quickly. Yet the impact on staff can be significant, creating moments of tension that are entirely avoidable with proper verification systems. Procedural safeguards are essential. Verification of credentials before questioning staff, clear communication between hospital administration and enforcement agencies, and reliance on documented evidence over subjective impressions reduce the risk of misidentification. The incident demonstrates that even well-intentioned officers can make assumptions that affect professionals doing routine work. This event also highlights the importance of transparency in verification processes. Clear protocols, consistent badge scanning, and accessible records allow both hospital staff and external agents to operate efficiently. They provide objective confirmation of authority and responsibility, minimizing unnecessary disruption to patient care. For viewers, the situation offers a quiet but instructive example of how professional environments balance security, procedure, and daily responsibilities. It emphasizes that systemic solutions, procedural clarity, communication channels, and adherence to verification standards are more effective than addressing individual behavior alone. In this context, bias is not about intent, but about the interaction between perception and procedure. The nurse was fully authorized and competent, yet assumptions introduced the possibility of escalation. Addressing these risks requires operational adjustments, not moralizing or dramatization. It demonstrates that professional protocols, when properly implemented, protect staff, patients, and institutions alike. Ultimately, the reflection is factual and measured. Procedural reliance on assumptions carries real-world consequences, and effective verification safeguards are essential. The incident is an example of institutional learning, illustrating how small adjustments in verification and communication can prevent similar situations, ensuring professional roles are respected and operational integrity is maintained. Have you ever been in a situation where your professional role was questioned or misinterpreted? Share your experience in the comments below. We'd like to hear how verification, assumptions, or procedural gaps affected your work or daily life. If you found this documentary story insightful, consider subscribing for more real-world investigations that examine how procedures and assumptions intersect in professional environments. Your observations help create a more informed community, and staying connected ensures you don't miss future stories that explore the balance between responsibility, protocol, and everyday professional challenges.